Great. The last of our formal talks of the conference is from Colleen Liu, who's going to tell us about cost utility from her TRD trial. Thank you, Colleen.
Thank you. You guys can hear this? Yes, we're waiting for the slides to come up. I think they're just coming up. Can I say that I believe from our experience that we need to track it specifically, and we do it before every single treatment. So, for example, we had someone who was actually a nurse, been receiving treatment for a year and a half, and then turned up for treatment one day having symptoms of probably a UTI, but didn't bother to mention it to us, despite us asking at every treatment 100 times before, do you have any urinary symptoms? Before giving her, hadn't occurred to her, it was relevant despite that. So I think we do a formal check with a formal checklist and officially ask and record the answer before every single treatment. Okay, so I'm going to talk about we've heard a lot about how useful ketamine is, but one of the big issues is, in Australia at least, it's not affordable. Unless you're quite wealthy and you can spend about $10,000 to $30,000 a year out of pocket, you don't get ketamine treatment. We've been applying to government for government funding, but of course the issue is you have to also demonstrate formally that from a health economics point of view, it is cost effective, through the usual kind of government committees. And so that's what we built into our recent RCT that we published, the KADS study we published last year. It's the largest phase 3 study of racemic ketamine versus a control in TRD. So I'll quickly mention the KADS study and then the health economics analysis with that. Here are my disclosures. All my research has been by competitive grant funding. In other words, we've been a very poor group. And my only commercial links are really having been on the advisory board for Janssen and also for Douglas Pharmaceuticals. Now, just to quickly tell you about the KADS study, some of you may not have read the paper. It was in TRD with no upper limit of treatment resistance. We had 184 people. We gave ketamine by a simple subcutaneous injection method. I think you've heard someone saying in this conference that it's highly dangerous, you get skin ulcerations. I don't know where that came from. In this study alone, we would have given over 2,000 treatments of ketamine with subcutaneous injection, and then combined with our subsequent clinics, over 10,000 treatments of ketamine by subcutaneous injection with not a single incident of skin ulceration. So I don't think that actually is a true statement. This study, it wasn't intended, but we ended up actually having 2 cohorts with different dosing methods, which I think is actually a very instructive finding in itself. And we had a very detailed safety evaluation. So we not only evaluated safety during the 2 hours after every treatment, but we also asked people before each treatment a detailed checklist of any side effects either persistent or emerging since the last treatment. So we also assessed for cumulative effects. We used midazolam as a control. We also did formal assessment of blinding, which is a very interesting data, which we are still analyzing. So I'm just going to do the first part of the study. So this is the randomization over 4 weeks, treatment given twice a week to ketamine or midazolam. Now, although prior to KADS, we had done a whole series of pilot studies which suggested to us that an individualized response-guided dosing protocol was the best. When I submitted our grant applications with that kind of dosing protocol, it was rejected as with a very low score. Because at that stage, this kind of adaptive methods in clinical trials was a big no-no. So a clinical trial specialist and collaborator said to me, Colleen, you just can't write that. So we wrote it with a set dose, and it was then probably the most highly rated psychiatry grant ever. We got a top score, and the princely sum of $2 million, which I think was the largest sum given to any individual mental health grant at the time in 2015. But as Paul Glue, who was both a psychiatrist and a clinical pharmacologist and a key collaborator, said to me, do you actually want to do this? And this is the dilemma you face as academic researchers. Do you write things that get through the grant body even though you don't think it's the best? Or do you write something that makes more sense clinically, but then you won't get funded? Having tried 3 times the second path, we then went to the first path. Now, at a routine DSMB meeting, and there was no formal analysis, they just pointed out to me, Colleen, not a single person, it doesn't matter what group they're in, not a single person is in remission. We think there's something wrong here. And I'm very grateful to Bill McDonald, the chair of the DSMB, for saying that. I think you guys need to just pause and rethink things, perhaps your dosing. So we did, and we refined the dosing going back to everything we had learned from the prior 6 years of pilot studies. So this time it was response-guided dosing. The concentration of midazolam and ketamine we used was such that at every level, it was an identical volume, both were clear solutions. All the drugs were prepared by clinical trial pharmacy in vials that were just labeled study drug. Even though we used commercial preparations of ketamine and midazolam, they actually dispensed those into study vial blinded vials. Now, and the dose increments were based on the MADRS, but we did a fairly slow titration schedule, so you couldn't hit the top dose until treatment number 6. Now, you see in the top graph, cohort 1, and there's no difference between midazolam and ketamine, although you do see some improvement in both groups. But where the groups separate is in cohort 2 with the response-guided dosing. Some people say to me, how come it was so slow, unlike the rapid response to ketamine? But you must remember that the majority needed to go to the top dose, which didn't kick in until treatment 6. And you can see that after treatment 6 is where the groups separate. If you look at the data from a remission and a response point of view, you can see that it was very highly significant, with the 20% roughly remission in the ketamine group versus 2% in the midazolam group. We found that the safety was excellent with a very careful monitoring. There were no serious adverse events. We had typical acute effects and no significant bladder problems or cognition. We did a formal neuropsych battery that's since been published, led by Donald Martin. So our conclusions from KADS were that this method, particularly with the response titrated dosing, was effective and also safe, and that the subcutaneous method was both very practical and also effective and safe. We deliberately had designed the trial with a 4-week treatment period and then a 4-week follow-up period to see what would happen if you didn't treat beyond 4 weeks. And you can, as you could see from the graph, that people tended to relapse. Now, I've just put side by side here our KADS results and also the Popova phase 3 acute treatment with Spravato studies. That you can see here that we had quite a sizable sample. We used a control drug with some active effects, which is why I think we saw some improvement in the midazolam group. We had no upper limit of treatment resistance, so a quarter of our sample had failed to respond to ECT. We had the definition of remission as MADRS of being 10 or less. One of our postdocs, Stephen Colleen, who's also a very clever mathematics degree as well as a neuroscience PhD, updated a meta-analysis of individual studies of racemic ketamine versus placebo and S-ketamine, both Spravato and other forms of S-ketamine versus placebo. And he actually looked at the results in 3 phases, as it were: the initial response to the first dose, the ongoing treatment response over a 4-week treatment period, and then 4-week follow-up after the last treatment. And you can see here that on all 3 outcomes, in fact, the racemic ketamine looked better. But of course, these are indirect comparisons. It's not a head-to-head comparison of racemic ketamine and Spravato. And we've now been funded to do that study, which I've called the TRD study. It will be a comparative effectiveness trial, so done in real-world conditions, recruiting from people who have already been accepted into a treatment clinic to receive ketamine. We've powered it to have 160 people. There's no upper limit to treatment resistance. So I know, for example, in my clinic, which is associated with a tertiary referral mood disorders unit, people come from all over the state. To my colleague, Philip Mitchell, who's an expert psychopharmacologist, once Phil has finished doing just about every other intervention, usually including ECT, TMS, and all the manipulations of medications, they then get sent to our ketamine treatment clinic. So that about 50% of people in our clinic have failed to respond to ECT. They'll all be entering this study. We'll be giving the subcutaneous injection and response-guided dosing. The primary outcome will be the MADRS, and we will be having a very detailed health economic analysis similar to what I'm about to show you. And we're about to commence when I get back to Sydney. Now, I should say I am not a health economist. When Rupert asked me to present this, my health economic experts said to me, but how will you actually present this, Colleen? And I said, well, I'll present your slides and just tell them that you guys are the experts who've done this, not me. We're very fortunate to have collaborators who are very expert, particularly Professor Mihalopoulos is considered one of the leading health economists in Australia, and is one of the experts who has served on the government expert committee that does the detailed evaluations of treatments, cost effectiveness, and what should be funded by the federal government in Australia. And so they applied similar methods to our study. So this is their slide explaining economic evaluation. Important equation at the bottom to note that the analysis that I'm showing is the incremental cost effectiveness ratio, and that is based on the difference in cost divided by the difference in benefit. Okay, so remember we're going to be comparing ketamine and midazolam, so the difference in cost and the difference in benefit. Now, we actually collected very detailed data on costs. So we collected health sector costs. So these are like direct health treatment costs for people while they were in the study. So this was collected at baseline, at the end of 4 weeks, and at the end of 8 weeks, including things like what medications you took, how often you saw the doctor, what kind of doctor, psychologist, etc., and all of those costs. We also collected societal costs, so that was how many days at work did you miss, or when you were at work, were you able to function at your full effectiveness, and things like carer time and transportation. So we actually used the AQOL-8D. It is a quality of life measure, but one that is liked by the health economists because you can derive from that utilities, which then can calculate quality-adjusted life years. There was also a detailed questionnaire which took about 20 to 30 minutes that assessed all of these health sector and societal costs that were completed by patients at those 4 time points. So we could also look at a change in those costs from baseline to 4 weeks and 8 weeks. And the majority of participants also gave us permission to access their national data in terms of Medicare services, and that's for all health services that have an item number with Medicare as well as drug prescriptions. So today I'm just going to present the incremental cost effectiveness ratio analysis. Now, and there are 2 ways of doing this. So in this very detailed study, even people in the control midazolam group all came to the treatment center, were given an injection, sat there for 4 hours after the first session, 2 hours after subsequent sessions, did a ton of ratings, etc. So they did all of this as well. Now, one way of calculating the cost is to say, well, the ketamine treatment costs were doing all of that, and the midazolam group also did all of those. The intervention costs were identical in the analysis. The other way of looking at it is to say, since midazolam is not a treatment for depression, we set that cost at 0, even though in the study, it obviously costs a lot to do that. To me, it doesn't make sense because we've heard about the placebo effect, etc. A lot of the effect of what happened in the midazolam group, I think it's because of all this coming and going, having multiple injections, ratings, etc. So to me, it doesn't make sense when you come to the health economic comparison to say that the ketamine group, we count all of these costs of all the personnel time, and midazolam, we count nothing. So our base case 1 is to actually count the intervention costs for both groups. Apparently from a health economics point of view, it's often done the other way, so we did put that in as base cost 2, where you count as if absolutely nothing, not a single cent, was spent on the midazolam group, which, as I said, to me, as a clinician, doesn't make sense. Here is the AQOL measure. As I said, from that you can calculate the preference-weighted utilities, and from that you can calculate the quality-adjusted life years. So in Australia, for example, our federal government funding for services is all based on how many thousands of dollars per QALY. And one QALY, a perfect score of 1, means perfect health for a 1-year period. A score of 0 would mean death. So the analysis looked at the costs. So what was the cost, the interventions plus health services. A secondary analysis was the societal costs. And then the QALYs, the benefits. So you've got the costs, the benefits, and then remember that equation I put at the top for you of the incremental cost effectiveness ratio. And you can see here all the details of how the analysis was done. Now, I should say first up that in cohort 1, there was absolutely 0 difference in the benefits as in the QALYs calculated. So there was no point going any further because that was just 0. So from here on, I'm just going to be showing the analysis of cohort 2. Cohort 2, for example, here are the health services costs that were actually collected from the groups. And there do appear to be some differences. They happen to be slightly higher in the ketamine group on some items, midazolam group on other items, but none of these differences were significant. Now we come to the benefits. And you can see here in the graph, these kind of utilities that are calculated from the AQAL score. And you can see here that in the intervention group, in the ketamine at 4 weeks, there was a clear advantage compared to the midazolam control group. You can then see in the bottom table that there was a difference in terms of the actual QALYs. You can see at the bottom, at both 4 weeks and even 8 weeks. So that ketamine had a higher QALY improvement at both 4 weeks and 8 weeks than the midazolam group. So then when you come to calculate the incremental cost effectiveness ratio, remember you're looking at the cost as well as the benefit counted in QALY units. And so it came out that when you look at health sector costs, that ketamine was dominant. Dominant is the term that means it was both less costly and more effective. So it was found to be dominant, in other words, cost effective, at both 4 weeks and 8 weeks for health sector costs. That's all the, like what medications did you have, how often did you see the doctor, etc. When it came to societal costs, that's things like your, how many days you missed at work, etc. That was not found to be cost effective. And here is that kind of data shown in graphs. So if you look at this graph, that the x-axis, as you go along the x-axis, you're having increasing benefit. As you go up the y-axis, you're having increasing cost. So ideally, you want your intervention to lie in this sector. In other words, it's both more effective and less costly. And you can see that for modeling of the health sector costs, ketamine versus midazolam largely fell within that sector and also at the 8-week mark. Whereas for the societal costs, it didn't. It still showed more benefit, but it was not clearly less costly than midazolam. And you can see that both at 4 weeks and also at 8 weeks. So to sum up the findings, based on our KADS study, that if you count the cost of midazolam, which was not nothing, these people, as I said, came and went, had all these injections and filled up multiple things and spent a lot of time with us, then ketamine was cost effective. And I don't know about other countries, I'd be interested to know, but apparently in Australia, our cutoff for getting Medicare funding is $50,000 per QALY. So that ketamine would be cost effective at the threshold of $50,000. And apparently the health services cost, that calculation, is what is used by our government in terms of assessing is something cost effective. That's the primary outcome, not the societal costs. If, however, you assume that the midazolam group treatment costs were absolutely zero, although I think a lot of the improvement you saw was because of all the coming and going, etc., then it was not cost effective. and the team is still doing additional analyses, etc. And ideally would like data over the longer term, which we hope to do in our next study. The KADS was a huge study, and there's a lot of people who contributed to this. To acknowledge, there's a lot more papers hopefully coming out from this. We've only published the RCT data. People will be publishing the open label data. We've published neuropsych. There will be papers on anxiety, suicidal ideation, blinding. We took blood in most people 4 hours after the first treatment, as well as blood for DNA, RNA, plasma, and serum. Bernhard Baun and Andrew Samoji are leading those analyses. And the George Institute provided a lot of clinical trial expertise. Okay.
Thank you very much for a great talk. Does anyone have any questions for Colleen?
Are you planning any? Hi. Oh, thank you, Bar. Are you planning any analysis in terms of cost-effective of ketamine compared to other treatment-resistant, other treatments for TRD like ECT or TMS?
It's a very good question because, that's one of the questions when we go up to this, if we have this application, do you cost ketamine compared to doing nothing? Like you have TRD or the on medications, you just continue, or you have ketamine, or you could cost it versus ECT. The issue there is having the data. So I don't know whether health economic analysis was built into the ANAND and XStrand studies, for example. You can do a kind of a analysis where you derive QALYs from depression scores. They do what they call a crosswalk, and then based on that, but you won't have the detailed health services costs because they have to be collected at the time. That's the detailed resource use questionnaire that we built into the study at the time it was done.
Thanks. There's a question at the back there. A couple of questions.
So forgive me, this probably just betrays my ignorance, but could you elucidate, again, what's the difference between the societal cost and the health service cost? What's the difference between those?
I know. It's so it was on one of the slides, but the health services are basically direct health costs. So seeing the doctor, the psychologist, having medications, all of those things, whereas the societal costs with things like the carer time off work, time not functioning 100% at work, time you spend, coming and going to appointments, those are considered societal costs.
Okay, thank you so much. That's really helpful. Cheers.
Somebody else at the back there.
Hi. Shouldn't IV ketamine be compared with this also?
Yes, in our study, because we had 184 people, it is the largest phase 3 study of racemic ketamine versus control for TRD, and we used the subcutaneous method because prior to this, we've done a number of pilot studies giving ketamine by the IV push over 5 minutes, intramuscular, subcutaneous. Based on that, we actually found the subcutaneous method was effective and safe. So that's the method we used in this study, and that's the method we use in our clinic. And the health economic evaluation was built into the KADS study, which gave ketamine by the subcutaneous method. You guys are doing IV ketamine. It's up to you to do the health economics around that method.
Yeah, because it takes 9 treatments to be different, to differentiate from the placebo. So, and sometimes ketamine IV in the first infusion, you already have a good differentiation. So that's what it seems like more costly. When you look at in the whole treatment, may not be more costly.
Yeah, so that was the conservative titration protocol we used for our study. In our clinic, we use a much more rapid up titration of dosage. So when we say, it's not that it took 6 treatments to kick in, but we didn't actually get to the top dose until treatment 6. So that's why you see it separating. In our clinic, we actually escalate the dose more quickly.
Okay. For a couple of questions.
Thank you for presenting your paper. When it came out, I read it with great interest, and I was really impressed actually by your blinding procedures and the questions you asked around blinding. And I believe you asked the participants to explain the reasons for their guess, which very, very few double-blind studies do in general. I'm curious I'm sure maybe this will come out in your upcoming paper. I'm curious to know your thoughts on the separation of the lines in cohort 2. Would you mind going back to that slide All the way back in the beginning, sorry. There we go. So I noticed, compared to cohort 1, sort of after maybe the 6th or 7th dosing session, the placebo and, midazolam and the ketamine lines start to separate, whereas that didn't happen in cohort 1 with the fixed dose. And I'm curious to know if there was any suspicion of an unblinding event or some other reason why participants might be unblinded at that point. My personal guess, which is just complete speculation, is that perhaps maybe folks in the midazolam placebo group were waiting for like a therapeutic effect or some dissociative experience to happen, and then by the time they were told, well, you've run out of doses to escalate to, like, this is the dose you're going to get, maybe some folks in the placebo group became dispirited or had a loss of hope, and therefore there was a reversion of the depression scores at that point.
Yeah, look, it's interesting. I think we reported in the main paper the blinding guesses for both participant and the blinded rater
right.
at the 4-week primary outcome time point. We had also collected the same information, which we're going to present in a subsequent paper after the first treatment.
Mm-hmm.
So it's interesting because I think what we found as a rule of thumb was that people who received ketamine had a higher proportion of knowing they received ketamine, but people who received midazolam by and large didn't know. But that actually happened in both groups, whereas it's only in cohort 2 that you see the efficacy. So the idea that the efficacy is all linked to a loss of blinding. In that case, we should have had an efficacious outcome also in cohort 1, which we didn't.
I guess, why, maybe I should phrase this differently, is why do you think that in cohort 2, the placebo group maybe had an early reversion to baseline scores, which you didn't see in cohort 1? Maybe that's just noise, I don't know.
Yeah, I mean, the placebo group doesn't look that different to me between cohort 1 and cohort 2. The difference is the red line.
Maybe the red line going down.
Group.
Yeah.
It's the red line. And the reason it doesn't kick until treatment 6 is because that's when people got to the maximum dose. Because we only incremented the dose at treatments 2, 4, and 6. If they hadn't improved by 50% from the baseline score.
Okay, yeah, thank you. I appreciate your explanation of that. Again, really, really good paper. And
we did a blinded MADRS rating before every treatment.
Yeah, no, it's fantastic that the amount of interrogation you did into blinding and
It's going to be a separate, very complicated paper on that, which thankfully somebody else is leading in our team.
I look forward to it. Thank you.
Okay, thanks very much. I think we're probably out of time there, so thank you very much, Colleen. I'm just going to...